Surgical Radiography 2 by Brandy Jones. Surgical radiography procedures. There are many types of surgical procedures that require the use of X-ray. We can break them down into categories by body part to make it a bit easier to learn. The surgical procedures by body part will go as follows. Chest region. Insertion or removal of portacaths, bronchoscopy, insertion or removal of pacemakers, insertion of other lines. Example would be a PICC line. Portacaths. In medicine, a port or portacath is a small medical appliance that is installed beneath the skin. A catheter connects the port to a vein under the skin. The port has a septum through which drugs can be injected and blood samples can be drawn many times, usually with less discomfort for the patient than with more typical needle stick. Chest x-ray showing a portacath. This is an example of a portacath. C-arm orientation. Generally, the C-arm is in an AP position. Your patient is usually supine. The IR is centered over the chest region where the port will be inserted. Usually the port is inserted on the right upper side of the chest. There are times where the surgeon will go in from the left upper side of the chest. You will be looking for tip and diaphragm with the C-arm. You may be asked to rotate the C-arm to shift the catheter off the heart of the spine. This would be obliquing your C-arm. Bronchoscopy. A bronchoscopy is a technique of visualizing the inside of airways for diagnostic and therapeutic purposes. An instrument, a bronchoscope, is inserted into the airways, usually through the nose or mouth, or occasionally through the tracheostomy. This allows for the practitioner to examine the patient's airways for abnormalities such as foreign bodies, bleeding, tumors, or inflammation. Specimens may be taken from inside the lungs. This is a physician with a bronchoscope. Purposes: diagnostic, to view abnormalities of the airway, to obtain tissue specimens of the lung in a variety of disorders, specimens that may be taken from inside the lungs by biopsy, a bronchoalveolar lavage, or an endobrachial brushing, to evaluate a person who has bleeding in their lungs, possible lung cancer, chronic cough, or sarcoidosis. Purposes: therapeutic, to remove secretions, blood, or foreign objects lodged in the airway, laser resection of tumors, benign tracheal and bronchial structures, stent insertion to palliate extrinsic compression of the tracheobronchial lumen from either malignant or benign disease processes. Bronchoscopy is also employed in percutaneous tracheostomy. A tracheal intubation of patients with difficult airway is often performed using a flexible bronchoscope. Bronchoscopy. X-rays of a bronchoscopy. Now notice below you have HQ Orthopedics. That is the mode selected on the C-arm. Sometimes different modes will make it easier to see this better. You might have to play with your C-arm. C-arm orientation. The C-arm is in an AP position. The physician will tell you when to come in with the C-arm and center over the patient's chest. Ideally, you want to place the end of the bronchoscope in the center of the screen. They may ask you to magnify the image. They may also ask you to put the C-arm in an LPO or RPO position. Pacemaker insertion. A pacemaker or artificial pacemaker so as not to be confused with the heart's natural pacemaker. It is a medical device that uses electrical impulses delivered by electrodes contacting the heart muscle to regulate the beating of the heart. The primary purpose of the pacemaker is to maintain an adequate heart rate, either because the heart's native pacemaker is not fast enough, or there is a block in the heart's electrical conductive system. Modern pacemakers are externally programmable and allow the cardiologist to select an optimum pacing modes for individual patients. Some combine a pacemaker and a defibrillator in a single implantable device. Others have multiple electrodes stimulating different positions with the heart to improve synchronization of the lower chambers of the heart. Here is an example and some pictures of pacemakers. Chest x-ray showing pacemakers, PA and lateral. Generally, PA and lateral are performed after the insertion of a pacemaker. You are asked not to raise the left arm above 90 degrees from the body and above the head. C-arm orientation. The C-arm will be in an AP position. You will come across the patient on the opposite side, usually coming from the right-hand side of the patient. You will center the C-arm over the left center of the patient's chest. Other line insertions can consist of PICC lines, central line, triple lumen, Hickman catheters, and other lines. All of these lines are discussed in your portable mobile radiography. PICC line. A PICC line is by definition and as per acronym, a peripheral inserted central catheter is a long, slender, flexible tube that is inserted into a peripheral vein, typically in the upper arm, and advanced until the catheter tip terminates in the large vein in the chest near the heart to obtain intravenous access. It is similar to the central lines and as it terminates into the large vessel near the heart. However, unlike other central lines, its point of entry is from the periphery of the body, the extremities, and typically the upper arm is the area of choice. Here's an example of a PICC line chest radiograph. The arrow showing the tip in the SVC. Orthopedics. Orthopedics is a study of the musculoskeletal system. Orthopedic doctors, often called orthopedists or orthopeds, specialize in diagnostic and treatment of problems of the musculoskeletal system. The musculoskeletal system includes bones, joints, ligaments, tendons, muscles, and nerves. ORIF. ORIF is an abbreviation for Open Reduction Internal Fixation. Open reduction internal fixation is a method of surgically repairing a fractured bone. Generally, this involves either the use of plates and or screws or an intramedullary rod to stabilize the bone. Here is some examples of an ORIF of the clavicle. This is an example of your C-arm setup. This is called the beach chair setup. Here's the radiograph afterwards. Here is an ORIF of the shoulder. ORIF of the shoulder. Another example of the ORIF of the shoulder. ORIF of the humerus. This is the humerus during surgery. An ORIF of the ankle. And during surgery. An ORIF of the tib fib x-ray. And the tib fib during surgery. ORIF of the femur. Here's some more pictures of the femur. ORIF of the hip. An additional ORIF of the hip. More of the hip. As you can see, there's many different ways to repair. ORIF of the hip. C-arm orientation. AP and lateral position of the C-arm is used. One of the easiest cases to use a C-arm is the ORIF of the hip. Usually a shower curtain technique is used. An X-ray is used for most of the entire case. Here is an example of ORIF of the hip. Looks like they decided not to place the shower curtain. Approaches to hip surgery. When there is a fracture below the femoral neck, an ORIF of the hip is the surgical procedure that is needed. When the fracture is through or above the femoral neck, a total hip replacement is the surgical procedure that is needed. Orthopedic surgical terminology: closed reduction. Fracture fragments are realigned by manipulation and are immobilized by a castor splint. The closed reduction is a non-surgical procedure. The fracture site of the patient is not cut open during the procedure. However, small pins are sometimes placed through the skin of the patient into the proper location and are left in place and later removed. Open reduction, ORIF, for several fractures with significant displacement or fragmentation, a surgical procedure is required. The fracture site is exposed, and a variety of screws, plates, or rods are inserted in as needed to maintain alignment of the bony fragments until new bone growth can take place. Images obtained from a C-arm unit or mobile radiographic unit frequently are used to guide the orthopedic surgeon during the surgical procedures. Internal fixation. During open reduction of fractures, a variety of compression plates, screws, pins, intramedullary rods, nails, or wires are applied to reduce or reline the fracture. Based at the age and condition of the patient, the type of procedure performed, and the extent of the fracture, these devices are left in place and the skin is closed around these devices. In some minor surgeries, these devices may be removed. External fixation. The use of an external fracture stabilizing device permits bone healing without immediate requirement for internal fixation. External fixators also can be used in conjunction with internal fixation procedures. Indications for external fixation include severe open fractures, comminuted closed fractures, arthrodesis, infected joints, and major alignment and length deficits. Intramedullary fixation. Intramedullary rods and nails are inserted within the shaft of the long bones to stabilize the fractures. This technique is popular in reducing shaft fractures of the humerus, tibia, and femur. Intramedullary fixation reduces the amount of tissue exposed during the surgery, decreasing surgical and healing time, and reduces post-surgical infections. Spine. Spine surgery: cervical, thoracic, lumbar, entire spine. Cervical spine fusion. Cervical spine fusion is a surgery that joins selected bones in the neck, see spine. There are different methods of performing cervical spinal fusion. Bone can be taken from elsewhere in your body or obtained from a bone bank. This bone is used to make a bridge between vertebrae that are next to each other. This bone graft stimulates growth of new bone. Man-made fusion materials may also be used. Metal implants can be used to hold the vertebrae together until new bone grows between them. Metal plates can be screwed into the bone, joining adjacent vertebrae. An entire vertebrae can be removed and the spine then fused. A spinal disc can be removed and the adjacent vertebrae fused. This procedure can be performed through an incision through the front, anterior, or the back, posterior of the neck. Here is an example of a cervical spine fusion. Here is a quick guide for surgery for a cervical spine anterior fusion. Here is posterior. Cervical spine discectomy. Anterior cervical discectomy is an operation performed on the upper spine to relieve pressure, one or more of the nerve roots, or the spinal cord. The procedure is explained by the words anterior, front, cervical, neck, and discectomy, cutting out the disc. Cervical spine discectomy needle location films. Cervical discectomy. This surgery uses an X-ray for a quick shot. The surgeon uses a needle to place in between the disc bases and then requests an X-ray to confirm that. Cervical spine discectomy. Use a portable to shoot a cross-table lateral C-spine with a plain IR. Use a C-arm to localize the needle placement. Some surgeons like you to leave the C-arm in the room in lateral position and left towards the patient's head. You can usually step out of the room during these procedures. They just call or page you when you need another shot and or picture. Cervical laminectomy. A cervical laminectomy is a procedure to treat spinal stenosis. The back of the spinal canal is removed by cutting the lamina to provide more space for the spinal cord and nerve roots. By relieving pressure on the spinal cord, it is the goal of the cervical laminectomy to stop the progression of damage to the spinal cord and allow for as much recovery of function as possible. Cervical laminectomy. This procedure usually does not require the use of imaging. Sometimes the surgeon may request a needle localization film. Lumbar fusion. A lumbar spine fusion is a type of back surgery designed to treat low back pain from degenerative disc disease. It is called a spine fusion because the surgery involves by placing small morsels of bone either in the front of the spine in the disc space or along the back of the spine in the posterior lateral gutter so that the bone grows together and fuses that section of spine. The fusion is designed to eliminate motion that is fused segment of the spine, therefore decreasing or eliminating the back pain created by the motion. Here's an example of lumbar fusion. Lumbar discectomy. The surgery is designed to remove the ruptured portion of the disc away from the injured nerve root. This usually results in relief of back pain and leg pain and may allow the muscles that are weak to regain their strength. Animation. Continued. A small incision in the skin over the area of the ruptured disc. The muscle is moved away from the lamina of the vertebrae above and below the level of the ruptured disc. Using an air drill or a special bone instrument, a little bit of lamina is removed to gain access to the disc. The main part of the surgery is then carried out by using an operating microscope or a special magnifying lens. Using special instruments, some of the ligament under the bone is removed and the nerve root is carefully moved. The ruptured disc is then found and removed from the nerve root. The disc space may be entered and an additional loose disc material removed. Bleeding is controlled, the wound is sutured together, and a sterile dressing is applied. When the disc ruptures the lateral to the facet, the incision is made more lateral so the disc can rupture can be approached more directly. X-ray and lumbar discectomy. Use a portable to shoot across table lateral L-spine with a plain IR. Use the C-arm to localize the needle placement. Some surgeons like you to leave the C-arm in the room in a lateral position and left towards the head of the patient. You can usually step out of the room for these procedures. They just call or page you when you need another shot. The surgeon only uses X-ray for a quick shot. The surgeon uses a needle to place in between the disc spaces and then requests an X-ray to confirm that. Lumbar laminectomy. First, the back is approached through a 2 to 5 inch long incision in the midline of the back, and the left and the right back muscle are dissected off the lamina and both sides at multiple levels. After the spine is approached, the lamina is removed, allowing for visualization of the nerve roots. The facet joints, which are directly over the nerve roots, may be undercut to give the nerve roots more room. Other types of spine surgeries requiring the use of X-ray. Vertebroplasty is a minimally invasive non-surgical procedure that is designed to relieve the pain of compression fractures. Vertebroplasty literally means fixing the vertebral body. In addition to relieving pain, those vertebral bodies that are weakened but not yet fractured can be strengthened, thus preventing future problems. Vertebroplasty. How is vertebroplasty performed? Under general anesthesia or sometimes under sedation, a special bone needle is passed slowly through the soft tissues of the back. Image-guided X-ray, along with a small amount of X-ray dye, allows the position of the needle to be seen at all times. A small amount of orthopedic cement is used and pushed through the needle into the vertebral body. PMMA is a medical-grade cement that has been used for many years in a variety of orthopedic procedures. The cement sometimes is mixed with antibiotic to reduce the risk of infection and a powder containing barium. which allows it to be seen on the X-ray. When the cement is injected, it is like a thick paste but it hardens rapidly. Usually each vertebrae body is injected on both on the right and left sides, just off the midline of the back. Within a few hours, the patients are up and moving around, and most go home the same day. Here are images of vertebroplasty. You can see here kyphoplasty. Kyphoplasty is a variation of vertebroplasty that attempts to stop pain caused by the bone fracture and attempts to restore the height and angle of kyphosis of the fractured vertebrae. Followed by its stabilization using injected bone cement. The procedure typically uses a small balloon that is inflated in the vertebral body to create a void within the cancellous bone prior to cement delivery. Once the void is created, the procedure continues in a similar manner, and as a vertebroplasty, the bone cement is typically delivered directly into the newly created void. Here are images. The use of the C-arm for these procedures. Most places will use two C-arms for this procedure. One C-arm will be in an AP position, the other C-arm will be in a lateral position. Have the doctor say AP and lateral instead of saying shot or fluoro. You will be needed the entire surgery. Two C-arms. Here is showing you how to set up. Scoliosis surgeries. ERCP, endoscopic retrograde cholangiopancreatography, is a technique that combines the use of endoscopic and fluoroscopic to diagnose and treat certain problems of the biliary and pancreatic duct systems. Through the endoscope, a physician can see the inside of the stomach duodenum and inject dyes into the ducts of the biliary tree and pancreas so they can be seen on x-rays. ERCP. ERCP is primarily used to diagnose and treat conditions of the bile duct, including gallstones, inflammatory strictures, leaks, and cancer. ERCP can be performed for the diagnostic and therapeutic reasons, although development of a safer and relatively non-invasive investigation such as magnetic resonance cholangiopancreatography, MCRP, and endoscopic ultrasound has meant ERCP is now rarely performed without therapeutic intent. Here are some images of ERCP. C-arm orientation. The patient is usually in an RAO or right lateral position. The C-arm will usually come from the right-hand side of the patient, the center of the C-arm over the center of the patient, between the chest and the abdomen. The patient is prone. Patient scope is at the bottom of the screen of the monitor. ERCP can also be done in a floor room. This is old school. Pain management procedures. The following slides give a description of pain management procedures that use X-ray. The most common types of pain management procedures that use X-ray are the epidural steroid injections. Facet rhizotomy injection. A facet rhizotomy injection in some low back pain programs, if 3 facet block injections provide a good but temporary relief of the patient's pain, a facet rhizotomy injection may be recommended. The purpose of the facet rhizotomy injection is to provide lasting low back pain relief by disabling the sensory nerve that goes to the facet joint. Facet joint injections. Facet joint injections are performed for facet joint pain. Facet joints can be injected with a long-acting local anesthetic and anti-inflammatory steroids, which can alleviate facet joint pain for long periods. Facet joint injection X-ray. Pulsed radiofrequency. Pulse radiofrequency treatment, passing alternating radiofrequency energy through tissues with significantly heating it can selectively inactivate pain-carrying nerve fibers, which tend to be smaller in diameter than the fibers that control the muscles and allow normal sensation. Conventional radiofrequency treatment results in the coagulation of all tissues at the tip of the needle, including all nerve tissue. In most situations, this does not matter, but in some situations, it is important to maintain as much normal nerve function as possible. Discography. Discography involves the insertion of a thin needle into one or more discs. Then either saline is injected into the disc to see if it is painful, the radiopaque contrast dye is injected, and x-rays will be taken to show the internal structure of the disc. Here is a picture of a discogram. Epidural steroid injection. Epidural steroid injection. The words epidural simply refer to the layer supporting the tissue outside the spinal cord. In an epidural, a solution of long-acting local anesthetic, a long-acting anti-inflammatory steroid, and sometimes other pain-modifying drugs is injected into the epidural space in the spine. ESI X-ray. Transforaminal epidural injection. A transforaminal epidural injection. This is an important adjunct to epidural steroid injection, and the two are normally done together. If you have lumbar radiography or cervical radiography, you will probably also have one or more transforaminal epidural injections. Here is X-ray of transforaminal ESI. SI joint steroid injection. The SI joint steroid injection is the first instance a solution of a long-acting local anesthetic, a long-acting anti-inflammatory steroid, and some other pain-modifying drugs is injected into both one or both joints. It is successful. The joint can be then denervated in a similar way to a facet joint denervation. SI joint injections. Nerve root block. Selective nerve root blocks for diagnosis and back pain management. Another common injection, a selective nerve root block, is primarily used to diagnose specific source of nerve root pain and secondarily for therapeutic relief of low back pain and or leg pain. Here is nerve root block X-ray. Lumbar sympathetic block. A lumbar sympathetic block is an injection. Needles will be positioned, and then there are three main ways to produce the block. Injection of a long-acting local anesthetic to produce a diagnostic block to safely see if your pain can be treated this way. Injection of a neurolytic substance such as phenol or alcohol to destroy the lumbar sympathetic nerves, and the use of radiofrequency energy to similarly destroy the nerves in the highly controlled way. A ganglion block. A stellate ganglion block. Stellate ganglion is a collection of autonomic sympathetic nerves which lies in front of the spine at the level of your larynx. It can be a site where pain signals from the face, heart, or arm are processed. It can therefore sometimes be useful to block it. Discectomy decompressor is a striker decompressor is a relatively new technique for decompression. They contain lumbar herniated discs. A special device the size of a needle is inserted into the affected disc. This then rotates like a drill, moving in some of the nucleus of the damaged disc, thus compressing it and allowing the bulge to reduce. This in turn reduces the pain from both the disc and the nerve root. Spinal cord stimulation. Spinal cord stimulation can be very effective at treating nerve pain and dysfunction from a number of different conditions. It has been shown to be particularly effective at relieving resistant nerve pain such as lumbar radiography following spinal surgery. It involves the implantation of a wire and a device that is the size of a matchbox. Here's an x-ray of the spinal cord stimulator. Sacral nerve root stimulation. A sacral nerve root stimulation. This is a new and effective treatment for the number of loosely related bladder and bowel control problems. The other main treatment alternative is a spinal cord stimulation. The main risk is infection, which occurs up to 5% of the patients. A pump plant, an intrathecal pump plant. An intrathecal drug delivery devices are advanced pain management systems for the patient whose pain cannot be adequately controlled by conventional oral or systemic analgesics. Delivery of a strong painkiller, such as morphine, directly into the cerebrospinal fluid can avoid many of the unpleasant side effects of conventional drug delivery. Here's a picture of a pump implant. C-arm orientation. Pain management cases are the best way for students to get to learn the C-arm. These procedures are done non-sterile, meaning the surgery table and the C-arm are not draped. This is easier for the students to visualize the C-arm over the patient. An oblique, cephalic, and caudal positions of the C-arm are used, sometimes even lateral. Images for pain management. Some more images. Tech tips for using the C-arm. Always get your C-arm into position with the annotation button selected prior to the first exposure. Pay attention to the surgeon and his or her hands and eyes. When the surgeon is not watching the monitor, do not fluoro. Hold the fluoro button down for at least 2 seconds or longer to get the patient's clearer image. Make sure everyone in the room is wearing a lead apron, thyroid, and dosimeter. It's your license on the line. Learning each and every procedure will make you a better OR tech. Practice with the C-arm when not busy.